Hello guys, welcome to the ninth chapter, and the ninth chapter is going to be about rheumatology. We're going to cover RA, rheumatoid arthritis, SLE, gout, OA, septic arthritis, reactive arthritis, gout and CKD, and allopurinol HLA testing. So we have a lot of high yield topics within this one rheumatology chapter, and I tried to keep it very concise so that it's easier to memorize, easier to compare, and easier to know which diagnosis to go for and which test to use for them, and then what are the actual presentations. So everything that's here is high yield, all right? And again, this doesn't cover the topic extensively. This is just my revision notes that I'm going over and I'm making videos about. So after my exam, I'll be making in-depth videos about each and every topic. So if you guys would like to see those as well, just subscribe and follow along so that you guys can be updated when those videos get posted. Now to start off between these two topics, rheumatoid arthritis and osteoarthritis, a lot of questions come from these two topics and comparison between them, especially the mechanism, the testing for them, then what would be the blood test and the treatments for them. Now the mechanism of rheumatoid arthritis is going to be autoimmune synovitis with pannus destroys cartilage, whereas osteoarthritis is more degenerative and cartilage broken down. So you would expect osteoarthritis to be in much older patients. So usually for older patients between more than 50 years and increases with age, whereas the peak age of rheumatoid arthritis, as it's an autoimmune condition, is going to be between 30 to 50 years old, and where females are more affected than males. Then distribution for rheumatoid arthritis is going to be symmetric with MCP, PIPs, and wrist, and it's going to spare the DIPs. This is a very important point because DIPs are affected in osteoarthritis, all right, and especially the weight-bearing joints of the knees, the hips, CMC, and thumb, all right. Morning stiffness in rheumatoid arthritis is going to be for more than 1 hour because it's inflammatory in nature, whereas for osteoarthritis is going to be less than 30 minutes because it's mechanical in nature. Systemic features are going to be present in rheumatoid arthritis because it's not related to the joints, but it's a systemic condition. So we'll have fatigue, weight loss, and anemia in most of the patients. Whereas for osteoarthritis, we'll just have those joint arthralgias or limited motion. So no systemic features will be seen. Then for blood test, rheumatoid arthritis is going to have anti-CCP, which is more specific for rheumatoid arthritis, but we'll also have RF positive in 70% of the cases. But this does mean that in 30% of the cases, we won't have RF positive. So we have to go for RF, anti-CCP, and then we have to also check the elevated CRP and ESR, which are inflammatory markers. Osteoarthritis is going to have normal inflammatory markers. First line is going to be DMARD for rheumatoid arthritis, which is methotrexate, which is the gold standard. So if it's immune mediated, we go for steroids to reduce immune capability of the patient. So that means that we'll have lesser inflammation. Whereas for osteoarthritis, as it's joint related or degenerative disease, we'll have no DMARDs, but we will have paracetamol, topical NSAIDs, physiotherapy, and weight loss. I've not seen topical NSAIDs as a treatment, but it's one of the modalities. All right. So the AMC trap is that if the morning stiffness is more than 1 hour and it's inflammatory in nature, we have to think about rheumatoid arthritis, AS, psoriatic arthritis, SLE, and less than 30 minutes is most likely mechanical. So osteoarthritis would be more common. Then anti-CCP is more than 95% specific for RA, whereas RF is 70% specific for positive for RA, but also is elevated in SLE, Sjogren, hepatitis, and elderly. For the elderly, normal is going to be different than the normal that we've seen in young patients. So for SLE, the way I like to see it, so brain MD, which are ACR SLE criteria. So it is supposed to be more than or equal to 4 of the 11 criteria we have to diagnose with SLE. All right. So S is for serositis, O for oral ulcers, A for arthritis, non-erosive arthritis, and P for photosensitivity. That's SOAP done. Now moving on to brain MD, B would be blood disorders. R is renal with proteinuria more than 0.5 grams per day. A would be for ANA positive, sensitive but not specific for SLE. I is immunologic, which is anti-dsDNA, which is specific, and anti-SM for anti-phospholipid. N is for neurological disorders such as seizure, psychosis. M is for mylar rash or butterfly rash, and it spares the nasolabial fold. And D is for discoid rash seen in SLE. And those are the important facts for SLE. And this is an important table to remember because this is the criteria for the diagnosis of SLE. All right, now moving on to gout. So the important point that was given in Murtagh is that allopurinol should not be commenced during an acute attack. All right, if the patient is already on allopurinol when attack occurs, we continue it. Start allopurinol at least 2 to 4 weeks after the acute attack settles and the target uric acid concentration is less than 0.36 millimole per liter. Then acute treatment for an acute attack is going to be NSAID, especially indomethacin, or colchicine 1 mg, then 0.5 mg 1 hour later, or prednisolone if both of these are contraindicated. All right, then prevention is going to be allopurinol. We start minimum 2 to 4 weeks after the acute attack and cover with colchicine NSAID for the first 3 to 6 months. Then the Murtagh critical rule, as we stated above, is that allopurinol should not be started in an acute attack, and it can prolong or worsen the attack. All right, and if the patient has gout and also has CKD, then NSAIDs and colchicines are relatively contraindicated. And in these, we use intra-articular corticosteroid injection, which is the safest acute treatment in CKD. And then allopurinol, we use it with care. Dose is reduced. Febuxostat is an alternative to allopurinol. And then again, target uric acid is going to be less than 0.36 millimole per liter. Then reactive arthritis. This is a bit of a new topic that they have started focusing on. Before it was mentioned, but not as much, but now it has started to come up, especially in the February recalls. All right, then it used to be called Reiter syndrome, and sometimes they may give this old name. So it is a sterile inflammatory arthritis triggered by an infection elsewhere in the body. So usually it's going to be GI or urogenital tract. Then the classical triad can be, obviously we all know this, and can't see, can't pee, and can't climb a tree. So conjunctivitis or uveitis, urethritis or cervicitis, and plus arthritis. All right, and this full triad is only present in 1/3 of the cases, and most patients just have 2 or 3 of these features. Now the triggers are going to be post-chlamydia trachomatis, which is urogenital infection, post-GI with Campylobacter, Salmonella, Shigella or Yersinia. Then onset is going to be 1 to 4 weeks after the triggering infection, and features are asymmetric oligoarthritis, so lower limbs are predominantly affected. Then dactylitis or sausage digits, so their fingers inflame and look like sausages. Then there's going to be skin lesions, so keratoderma, blanorogica or sarcinate balanitis, and oral ulcers. Then the investigations of choice is going to be FBC plus CRP ESR to assess the disease activity, and the CRP and ESR are both inflammatory markers. HLA-B27 is positive in 80% of the cases, so this is an important investigation. Then it is associated with more severe and chronic diseases, this HLA-B27. Then swab NAT for chlamydia, because we have to check for what is the underlying disease that led to it, if it's still present or not. And we culture or serology for GI organisms. So all of this is going to be based, the microculture, the microbiology culture is going to be based on the history that the patient gives us. Then again, treatment as the same for osteoarthritis, that we had NSAID as the first line for arthritis, and we treat chlamydia if it's still active with doxycycline or azithromycin. Intra-articular steroids can be indicated if there is no improvement. Sulfasalazine or methotrexate for chronic diseases. All right, and the AMC key would be that the patient has it's a young person with arthritis plus urethritis or eye symptoms plus recent STI or gastroenteritis. All right, first investigations are FBC, CRP, HLA-B27 testing if the diagnosis is confirmed. All right, now moving on to allopurinol and HLA-B58 testing, which is new. It was mentioned in the February recalls, is that it is strong that this particular allele is strongly associated with severe allopurinol hypersensitivity, which is SJS, and toxic or TENs, so toxic epidermal necrolysis, severe reaction. And high risk population are Han, Chinese, Vietnamese, Thai, Korean population, as they are the carrier frequency for them is 6 to 8%. Then we screen these populations specifically for HLA-B58 01 before we start allopurinol in Han, Chinese, and other high-risk Asian populations. If it's positive, we do not start. Obviously, we use febuxostat instead, and because it's an alternative urate lowering therapy. All right, and if it's negative, that means allopurinol is safe. We can continue the same way, and also applies to carbamazepine diazepine in Southeast Asian population, and the key is that Chinese patient with gout needing allopurinol, we order HLA B5801 first. Alright, so this is one of the traps that AMC will set. And moving on to septic arthritis. We remember that reactive arthritis was sterile. Septic arthritis is not sterile. It's hot, swollen, exquisitely tender joint, systemically unwell as well. So pain with all passive movement, and this is the most sensitive sign, that if you grab the patient and move with them yourself, the joints that are affected, it's still going to be tender. Then the investigation of choice is that joint aspiration is going to be mandatory for these patients with white blood cell count of more than 50,000 cells per picoliter, with more than 75% being PMNs. All right, blood culture, FBE, ESR, CRP, and uric acid. Uric acid, why? We have to rule out gout as well. All right, organism, Staphylococcus aureus is the most common in adults. Group A, Streptococcus Neisseria gonorrhea is more common in young sexually active adults, and especially if they have migratory polyarthritis first. So group A strep or Neisseria gonorrhea in young patients if they have migratory polyarthritis first, and Staphylococcus aureus if it's more older generation. Then the treatment is going to be IV flucloxacillin or vancomycin if it's MRSA, and we do not delay for definitive culture. We just start the treatment. All right. And now moving on to gout and pseudo gout. The way to differentiate between them is that this table highlights everything, so it's very important for you to see, because I've seen a lot of questions, they give the crystal types and if it's birefringence positive or not. All right, so gout is going to be monosodium urate, whereas pseudo gout or CPPD is going to be calcium pyrophosphate dihydrate. These are the different crystal types between the actual gout and pseudo gout. Then birefringence is going to be negative in gout with needle shapes, and it's going to be positive and rhomboid shaped in pseudo gout. Then joint preference is going to be first MTP, podagra, ankle and knee for gout, whereas for pseudo gout it's going to be knee and most common, whereas knee and wrist. All right. So X-ray will see no calcification with gout, whereas for pseudo gout we have chondrocalcinosis, where the cartilage is going to be calcified in these affected joints. Treatment of choice is going to be the same for both. However, for gout we will give steroids in acute setting and allopurinol for prevention, whereas we give just NSAID and colchicine for acute attacks. We don't have any steroids, we don't have any equivalent of allopurinol. All right, and these are all the key numbers. This was the last section of this topic, all of the key numbers to remember. And yeah, this is it for today's short video, rheumatology. This is all the important facts I came across and important things to remember for my revision. But if you feel any topics were left out that are supposed to be included, if you felt that some of this information wasn't enough, especially for any topic, just let me know. I'll add more information to it. If you want, you can download these chapters from the group, the Telegram group. The Telegram group has all the past topics as well, and over there we also discuss all of the recall questions. The WhatsApp group is linked down as well, where we discuss exam related questions or how do you register if you're facing any problems. And if you have any questions and whatever topic you'd like to see, just let me know down below, and then we'll be sure to upload that as well. All right, thank you.